This is Pat Walter from the Surface Hippie website, and I'm in Baltimore today with Dr. Gross from South Carolina. Hi, Dr. Gross.
How are you doing, Pat? It's been a great meeting, and I'm glad you could come.
Thank you. Let's just review for people perhaps who don't know a lot about you yet. How many hip resurfacings have you done to date?
I started doing this 10 years ago, and I've now done over 1,800 hip resurfacings.
And what device do you normally use?
Currently, I'm using the Biomet Magnum Recap device. I was involved in designing that system. Before that, I used the CorMed 2000 device. I was the lead investigator of the FDA study that brought that device to the U.S.
I talked to you about a year ago, and of course you do the uncemented version, which I think you're probably the only surgeon in the United States doing that. Could you give us an update and tell us what's happening with the uncemented?
Certainly, that's my great passion. When I started hip resurfacing 10 years ago, I thought the way to fix these implants to bone was with a bone ingrowth technology, which we could call uncemented fixation. That's in fact the way all socket components are already attached in resurfacing. There's general agreement that that's the best way to attach a socket component. The problem is that cement was used to attach the femoral component early on, and all the data in hip resurfacing is based on that cemented component. I happen to disagree with the people who started hip resurfacing that that's the best method. With hip replacement, we've gone through that transition already. At this point, it's fairly well accepted in this country that particularly in young active patients, uncemented fixation of the femoral component of a total hip replacement is the better way to go, and certainly for both total hip and resurfacing, uncemented fixation of the socket is the better way to go. I've worked for 10 years to develop an uncemented femoral component. 2 years ago we were able to introduce that in the US, and that's what I'm using exclusively now. I think in the long run that's going to be the better way of fixing these implants long-term to bone, just because of the history we have with the socket already and with the femoral component. I've been doing this now for 2 years. I've put in close to 700 of those and have been monitoring the results very carefully, comparing them to my results with the same brand implant but with a cemented interface, which we started using 3 years before that, and there have been no differences at up to 2 years at this point. So in the early term, they seem to be equivalent. My prediction is that in the long term, there's going to be a more durable fixation to the bone. That's of course only one of the components of a resurfacing that has to work to make it work long term, but I've been focused on that for the last 10 years.
The uncementless placement is one of the newer issues. There are some changes happening in hip resurfacing, such as using different surgical approaches, different designs, some of the mid-head designs, and computer-assisted surgery. Where do you think any of these have a place in future hip resurfacing?
All of those are very interesting developments. The mid-head resection, there's really no opportunity to do that in the U.S. yet. I think that has a very small potential market in people who are have too much bone loss in the femoral head and still could have a more conservative or less bone removing operation than a regular total hip replacement. I would say that people who come to me who are interested in resurfacing, that would be maybe 2 or 3% of patients. I have to tell them they're not a good candidate for resurfacing, that I might be able to do something like this. It's not available in the U.S. yet. So it's an interesting option for mainly patients with osteonecrosis who have large defects of bone in their head. The other areas you talked about were surgical navigation. That's just a way of using a computer to gather data and use it to allow the surgeon to do a more accurate operation. There's lots of different types of navigations, and it's not clear really whether they will allow us to do a better job or not. Sometimes a bunch of extra data, if it's not gathered accurately in surgery, can lead to misinformation and actually doing a poor job. So I'm not convinced that that's the right way to go. I do believe that using CTs for three-dimensional data analysis before surgery, virtual implantation on a computer, and then translating that surgery has great promise. I'm starting to work on that. That's probably going to be about 3 to 5 years away before we can actually effectively do that in patients. And the expense will be significantly higher to do that, so I'm not sure how that's going to fly in the current economy.
What % of your hip replacements are resurfacings? Do you know approximately?
Yes, that my percentage is 90%, but
Okay.
but that's not appropriate for the whole country, and let me explain that. I'm a specialist in hip resurfacing. I've been doing it for 10 years, and I track those patients. They come from all over the country because they want to have resurfacing by someone who has a large experience. They don't want to go to the local doctor who's only done 10, and so people select me who are resurfacing candidates. So that dominates my practice. In this country, about 2 to 3% of hip replacements are resurfacings. In England, it's about 10%, which is the maximum anywhere in the world. I estimate that probably about 30 to 50% of patients who are candidates for a hip replacement would be well served by a hip resurfacing operation. So that gives you different ways of looking at it. So if I were a general joint replacement surgeon in the community, I can equally well do resurfacing and total hip replacement. I would say, you know, the ideal mix would be about 40 to 50% hip resurfacing. That's my opinion on that matter, and it would vary quite a bit.
There's always been talk about the increased metal ions after resurfacing. Could you talk about that a little bit?
Yeah, metal ions are the wear debris that comes off of an implant. So that's one of the factors to consider. Every artificial implant has particles that come off and are shed into your body, and your body has different ways of dealing with that. The three major types of bearings that we have in this country now are either a metal or a ceramic head against a plastic bearing, and what you see there is mostly plastic debris. Then you have a ceramic on ceramic bearing where you see mostly ceramic debris coming off, and in a metal bearing, of course, it's metal debris. It's cobalt and chromium, and there are other metal ions that come off, nickel, molybdenum. There are trace elements also in there. So the question really becomes, if you need a replacement, which bearing material is best? One of the factors to consider are the actual particles that come off, but there are many other factors to consider also. For instance, with plastic and ceramic bearings, you cannot currently do a hip resurfacing, and you're usually obligated to use an implant that has a smaller bearing size. There's not enough time to go into why that's so, but smaller bearing sizes have an inherent major problem that they're not as stable. So you have a hip joint that has a large head. Everybody's head's different, but whatever your size is, if you're going to put a plastic or ceramic bearing in there, you have to downsize it, and the negative on that is that you have higher rates of instability, hips dislocating, whereas if only with a metal bearing can you get the anatomic size of the hip reconstructed, whether it's a resurfacing or total hip, with a large metal bearing, and you have normal stability, lower risk of dislocations. And many studies have borne this out. So metal ions are normal in our body. First of all, cobalt and chromium are normal in our body. When we have a metal bearing implant, they are going to be higher in our body, but there does not seem to be a problem in most people who have these implants. There are a few reports with some patients who have problems with too high of a level, and we're investigating actively why that is. And one of the things that's come out in the last few years is that acetabular components that are put in more steeply may have a higher ion level. Doesn't mean every component that's steep has a high ion level, and unfortunately I'm starting to see some surgeons around the country recommending changing cups, removing cups if they're put in too steeply. Really, you need to correlate a steep cup with a high ion level and patient problems before you would think about removing that. On the other hand, what can we do now that we know that steeper cups in some patients produce higher ion levels? We need to make sure we put those cups in more horizontal. And I've developed a technique 2 years ago to do that. And at this point, it's possible to do a quick x-ray test in surgery, and we've tested the accuracy of that. And with plus or minus 5 degrees, we can get the component in the right position. So really there's no more need to have a cup that's too steeply inclined. It gets way more complicated than that, because there's not just the inclination of the cup, there's also the way it's angled and turned, and unfortunately there's no good way to measure that yet. Some surgeons kid themselves that they can, on a plain x-ray, tell which way that cup is angled, called anteversion, but that's really not possible off of a two-dimensional x-ray, and I'm getting ready to get started with the 3D measurement of those cups, and that's really what we need to do, CT measurements, to really figure out what the what the proper torsion angle, which we call in orthopedics anteversion angle is. That's highly controversial. There are people who think they can measure it off x-rays with computer programs. I'm highly skeptical of that, and so a lot more work needs to be done to fine-tune the position of the cup.
There also have been articles that women are not good candidates for hip resurfacing. What would be your response to that?
Well, I totally disagree with that. In most reports on hip resurfacing, women do have a higher complication rate with hip resurfacing. And if you look at that carefully, that may have several reasons. One may be because women have softer bone, and femoral neck fractures are our most common complication after surgery, so they're naturally more prone to that. But the rate, if you do the operation carefully, the rates in women are not that much higher. Maybe 0.5% in men compared to 1.5% to 2% in women. So yes, the rate is somewhat higher. We're working on all kinds of techniques to try to decrease that. There's not enough time to talk about that yet, and we don't have evidence yet. But women do have a higher fracture rate. That's one problem. The other problem is that a lot of young women who have early arthritis have dysplasia. Dysplasia is a complex deformity of the head and socket. And those patients have higher problems with total hip replacement also. So it's not just that they have more problems with getting a resurfacing aligned properly and working well. They also have the same problems with total hip arthroplasty. And so to say that they're not a candidate for a resurfacing, but they're a candidate for a total hip replacement is absolutely false. What we really need is a good comparison study in those dysplastic younger women comparing head-to-head resurfacing and total hip replacement to answer that question. I think in the long term the resurfacing is going to be the better option for those patients comparing them to total hip, but I have no evidence for that.
So in reality, it isn't whether you're male or female, young or old, the doctor needs to look at each individual patient and decide if they're a candidate.
That's absolutely true, and it is true that women have higher complication rates, but they also do with total hip replacement. So a woman patient has to understand that, but that doesn't mean she's not a candidate for hip resurfacing. I think they still do very well with hip resurfacing in general.
Could we close with you perhaps talking about what the positive aspects of hip resurfacing are compared to a total hip replacement?
There are many. And it depends on how you look at it. If you look at broad studies, which we look at in joint registries, where we look at take a very superficial look at the results of patients who have resurfacing and total hip and other implants, the results are very equivalent between resurfacing and total hip arthroplasty out to 8 years of follow-up. And in some particular patient groups, resurfacing shows slightly better results, and some total hip shows slightly better results. I think that misses the point, though, a little bit. This operation is really for the younger person to preserve bone stock. And even though we've made tremendous advances in hip replacement with modern bearings, ceramic bearings, better plastics, that means cross-linked polyethylene bearings, metal-on-metal bearings, we've made tremendous advances in the fixation of the implants to bone, uncemented socket fixation, now uncemented stem fixation and total hip replacement. We still only in the most modern and best type of hip implants have about 8 years of data. We're putting these implants into people 40, 50 years old, and they're going to be needing them for 20, 30, 40 years. So if I can get the same result with a hip resurfacing on a group of 100 patients than I can with a ceramic on ceramic total hip or any other total hip, my preference would be to do a resurfacing, preserve the bone, and give them better options in the future.
Well, thank you very much for taking time to talk to me. I know a lot of prospective patients will listen and learn. And thank you.
Thank you very much, Pat. Thanks for coming to this meeting.